So today it is about discussing how to examine a
So I
chest
want you to
pain patient.
imagine you're sitting in the emergency room, the fluorescent lights are buzzing, monitors are just aggressively beeping, and someone has just been rushed through the double doors clutching their chest.
Right, and from the outside, that scene usually feels completely chaotic.
Yeah.
Like medical staff are rushing around, they're shouting out numbers, grabbing equipment.
Exactly. But what looks like pure chaos is, in reality, a highly choreographed, incredibly precise dance.
It really is. It's a rapid-fire sequence of data collection where, honestly, every single second dictates a life or death decision.
Right.
The medical professionals in that room aren't scrambling. They are executing a very specific, deeply ingrained map.
And that map is the focus of our deep dive today. Our source material is a standard clinical protocol used by doctors. These are the actual guidelines aligning with the American College of Cardiology, the European Society of Cardiology, and major medical board exams.
Yeah, it's essentially the ultimate medical cheat sheet for how to examine a patient presenting with chest pain.
Right, because its singular purpose is to rapidly identify catastrophic, life-threatening conditions. I mean, when someone says chest pain, we immediately assume it's a heart attack.
Which is a safe guess. But the chest is a really crowded neighborhood. You have the heart, the lungs, the massive pipes of the aorta, the esophagus. Any one of those could be sounding the alarm.
True. So our mission today is to decode this clinical cheat sheet for you. We're going to unpack how doctors hunt for these invisible threats, and we're going to reveal the fascinating, totally hidden language our bodies use to signal when something is breaking down. Okay, let's unpack this. Starting with the fact that before a doctor even pulls out a stethoscope, before they even say a single word, the examination has already begun.
Oh, absolutely. The moment a doctor crosses the threshold of that room, they are downloading massive amounts of visual data. They scan for overt signs of distress.
Like what? What are they looking for right off the bat?
Well, they look for diaphoresis, which is this profound, cold sweating caused by the nervous system just going into overdrive. They look for cyanosis, a bluish tint to the lips or skin indicating oxygen isn't reaching the tissues.
Wow. Okay.
And they assess overall body habitus, like whether a patient is obese or suffering from cachexia, which is a state of severe physical wasting. But the most immediate high-yield clue is simply how the patient is positioning their own body.
The protocol lays this out so beautifully. Like if a patient is lying completely immobile, actively trying not to move a single muscle, that strongly suggests acute coronary syndrome, a heart attack.
Exactly. Because every tiny movement requires oxygen, and their heart muscle is currently starving for it.
Yeah.
The body intuitively knows it can't afford the energy expenditure.
Right. Contrast that with a patient who is, say, sitting forward, hunched over their knees. That posture points heavily toward pericarditis, which is an inflammation of the sac surrounding the heart.
Yeah, and there's a mechanical reason for that.
So leaning forward physically shifts the heart downward and away from the chest wall. Right, like relieving the pressure on that inflamed sac.
That is the exact mechanical reason, yeah. It physically pulls the irritated tissues apart. Now, on the flip side, imagine a patient who physically cannot lie flat.
Like they start panicking.
Right. The moment the bed is reclined, they panic and start gasping for air. That points directly to heart failure.
Because of the fluid, right?
Exactly. When you lie flat, gravity pulls all the fluid from your legs and abdomen back into your main bloodstream. A healthy heart simply pumps that extra volume forward. But a failing heart is a weak pump.
It just can't handle it.
It can't handle the sudden influx of fluid, so that fluid backs up into the lungs, and the patient literally feels like they are drowning in their own bed.
That makes perfect sense. And if they're leaning hard to one side, like clutching their ribs, that's likely pleural pain. The lining of the lungs is inflamed, and the patient is instinctively splinting that side to stop the lung from expanding when they breathe.
It's incredible. It is pure survival instinct playing out in real time.
It really is. Now, once the visual assessment is done, the doctor immediately moves to secure the most critical functions. The ABCDE primary survey, focusing on the airway and breathing.
Right. They listen for stridor, which is this high-pitched, frankly terrifying wheezing sound that means the main windpipe is physically blocked. And they check if the patient is using accessory muscles.
Which means looking at the neck and shoulders, right? Because normal breathing is supposed to be passive, driven by the diaphragm.
Exactly. If someone has to visibly heave their shoulders just to pull in air, their primary breathing mechanism is failing, and respiratory collapse is imminent.
Which brings us to checking circulation and neurological function, the C&D of the survey. And here is where the protocol gets incredibly revealing about the plumbing of the human body. The doctor needs to check the patient's level of consciousness, looking for confusion, agitation, or focal neurological deficits like hemiparesis, which is sudden weakness on one side of the body.
Wait, I have to jump in here.
Go for it.
Wait, why are we checking for confusion and focal neurological deficits like hemiparesis if the patient is complaining of chest pain?
Right, that sounds like a stroke, not a heart issue.
Exactly. But what's fascinating here is the connection between the chest and the brain. Think about the aorta. It is the massive pipeline taking high-pressure blood directly out of the heart.
The main water main, basically.
Right. An aortic dissection occurs when the inner lining of that pipe tears. Blood surges into the wall of the artery itself, violently ripping it apart.
Patients often describe that as a tearing pain radiating straight through to their back, don't they?
They do. But the neurological connection is the key. That tear in the aorta can rip upward and extend directly into the carotid arteries, which are the main branches supplying blood to the brain.
Oh, wow. So the tear in the chest essentially cuts off the blood supply to the brain.
Yes. The sudden confusion or one-sided weakness is the brain suffocating because the tear has compromised the carotid arteries.
That is wild.
If an ER doctor sees a patient with chest pain who suddenly cannot move their left arm, they aren't assuming it's a heart attack and a coincidental stroke. They know the aorta is tearing from the chest all the way up into the neck.
Brilliantly logical and absolutely terrifying.
Seriously.
After clearing those immediate threats, getting vital signs, and checking the chest wall for trauma, or even a shingles rash, which by the way causes intense burning nerve pain, the protocol pivots.
They don't go straight for the heart.
Right. They zoom all the way out to the body's furthest extremities. They start inspecting the hands. And honestly, it amazed me that an ER doctor looks at fingernails for chest pain.
Oh, fingernails act as a historical record of cardiovascular health. Doctors look for clubbing, where the ends of the fingers physically bulge out and the nails curve over like upside-down spoons.
Why does the finger actually change shape like that?
It is a response to chronic, long-term low oxygen levels, often from congenital heart disease or severe lung disease. The body tries to compensate for the lack of oxygen by opening up tiny blood vessels in the fingertips.
Oh, I see.
Yeah, and that causes the tissue to swell and change shape over time. They also check the nails for splinter hemorrhages. Tiny, thin, red lines that look exactly like wood splinters trapped under the nail bed.
Those are actually tiny blood clots, aren't they?
They are microemboli. If a patient has endocarditis, which is an infection of the heart valves, colonies of bacteria and clotted blood actually grow on the valve.
Gross.
Yeah, and little pieces of that infected mass break off, get pumped out of the heart, travel all the way down the arm, and get wedged in the microscopic capillaries right under the fingernail.
Finding evidence of a heart infection lodged in a fingernail is just wild to me.
Highly.
So from the hands, the doctor moves up the arms to assess the pulses and blood pressure. They check the pulse rate and rhythm, but they also check for delays, like a radial delay, where the pulse in one wrist hits a fraction of a second later than the other, or a radiofemoral delay, where the wrist and the groin just don't sync up.
Right, and the protocol specifically demands checking blood pressure in both arms if a large vessel issue is suspected.
This part makes me think of the plumbing in an old house. Like if you turn on the kitchen sink and the water pressure is great, you just assume the main line from the street is fine. But if you walk into the bathroom and that sink is barely trickling, you instantly know there's a blockage somewhere in the pipes between those two specific rooms.
That is a perfect analogy, because in a healthy vascular system, the blood pressure in your right arm and your left arm should be nearly identical.
Right. So if a doctor checks both arms and the pressure in the right arm is, say, 120, but the pressure in the left arm is 80, what is happening mechanically to cause that drop?
We are back to the aortic dissection.
Yeah.
As that inner lining tears and creates a false pocket for the blood to flow into, that flap of ripped tissue can flop over and physically block the exit ramp leading to the left arm, the subclavian artery.
Wow.
Yeah, so the right arm gets full, unobstructed pressure, but the left arm gets choked off. Finding a significant inter-arm blood pressure difference is a blaring siren for a torn aorta.
Tracing the plumbing further up, the doctor examines the neck and face. They check the jugular venous pressure, the JVP, looking for bulging veins in the neck that indicate fluid backing up from a failing right heart.
And they check for pale skin under the eyelids and yellow cholesterol deposits around the eyes called xanthelasma.
But the text also says that if a hypertensive crisis is suspected, they use a fundoscope to look deep inside the eye for papilledema, hemorrhages, or exudates. I have to ask, shining a light into the eyeball to investigate chest pain seems like a massive leap. Why look in the eyes for chest pain?
Because the back of the eye, the retina, is the only real estate in the human body where a doctor can look directly at bare blood vessels without needing a scalpel.
Oh, wow. So it's essentially a transparent window into the cardiovascular system.
Exactly. If a patient has chest pain and off-the-charts blood pressure, the doctor needs to know if that pressure is a temporary stress response or if it's a chronic destructive force, a hypertensive crisis. By looking into the eye, if they see grade 3 or 4 hypertensive retinopathy, maybe the microscopic blood vessels in the retina are physically bursting, bleeding, and leaking fluid, they can confidently assume that same catastrophic microscopic damage is happening to the vessels inside the heart and brain.
The eyes truly are the window to the vascular system. That is incredible.
It really is.
So moving from the neck straight down into the engine room itself, the chest, the precordial examination. This starts with palpation, physically pressing on the chest wall. They feel for heaves, where the heart is working so hard it literally lifts the doctor's hand. And thrills, which the source describes as feeling like the vibrations of a purring cat caused by violently turbulent blood flow.
They also press on the joints where the ribs meet the breastbone, checking for costochondral tenderness. If pushing on the chest wall reproduces the exact pain the patient came in for, the doctor can breathe a slight sigh of relief.
Really? Why is that a relief?
It generally indicates the pain is musculoskeletal, like costochondritis, rather than a failing organ.
Got it. Then comes auscultation, listening with a stethoscope. They use both the diaphragm and the bell to listen to the 4 main valve areas: aortic, pulmonary, tricuspid, and mitral. They are listening for the standard lub-dub, the closing of the valves.
Right, S1 and S2.
But here's where it gets really interesting. The protocol outlines the wild extra sounds a failing heart can make, like an S3 gallop.
Oh, an S3 gallop is fascinating. It sounds exactly like a horse galloping. Lub-dub-dub, lub-dub-dub. Mechanically, it happens when blood sloshes into a dilated, overly stretched out ventricle.
Oh, wow.
Yeah, that extra dub is the sound of fluid hitting a floppy wall, and it heavily suggests acute heart failure.
Then there are the murmurs, a new apical holosystolic murmur. The source notes this suggests a papillary muscle rupture, which is a catastrophic complication of an acute MI, a heart attack. What exactly snaps inside the heart to cause that?
Okay, so the valves inside your heart are held in place by tiny parachute-like tethers called chordae tendineae, and those are anchored by papillary muscles.
Okay, I'm picturing it.
If a heart attack kills the blood supply to that specific muscle, the tissue dies, and the tether can literally snap.
So the valve door is just blowing backward in the wind.
Unrestrained. Every time the heart pumps, blood rushes violently backward through that broken door. That turbulent backward flow creates a loud, whooshing murmur that lasts through the entire heartbeat. That's the holosystolic part.
That is terrifying.
Yeah, and alternatively, a new diastolic murmur sounds like blood leaking backward while the heart rests, which points again to an aortic dissection that has torn all the way down and broken the aortic valve itself.
Of all the sounds in the source text, though, the one that made me physically wince is Hammond sign. It describes a precordial crunching sound synchronous with a heartbeat, literally a crunching heart.
Yeah, it is a distinct crackling noise. But it's not the muscle itself crunching. It points to pneumomediastinum, which is air inappropriately trapped in the center of the chest cavity. This often happens with Burhaave syndrome.
Which is a spontaneous, violent rupture of the esophagus, usually from severe vomiting, right?
Exactly. The esophagus tears, air leaks out into the chest cavity, and every time the heart beats, it squishes that trapped air against the breastbone, making a crunching sound.
Ugh. You might even feel that same crackling trapped under the skin of the neck or chest wall, called subcutaneous crepitus. It literally feels like pressing on bubble wrap hidden just under the skin.
It's a very distinct tactile sensation.
I don't think I'll ever forget that description. Now, to catch some of these more subtle sounds, the protocol dictates dynamic maneuvers, like the doctor might have the patient lean forward and forcefully exhale, or perform a Valsalva maneuver, which is standing up or bearing down like you're trying to pop your ears.
Right.
But wait, why make a patient who is already in severe pain do breathing gymnastics? It seems kind of cruel.
It does, but there is a fluid dynamics reason for it. The heart is a dynamic pump, and altering your body position shifts the volume and pressure of the fluid. When you lean forward and push all the air out of your lungs, you are physically bringing the heart closer to the chest wall. This eliminates the cushion of air in the lungs, making it much easier to hear the quiet murmur of aortic regurgitation or the scratchy sandpaper sound of a pericardial friction rub.
Oh, that makes sense. And bearing down with the Valsalva maneuver dramatically decreases the amount of blood returning to the heart, right? By temporarily starving the heart of blood volume, doctors can differentiate between different structural problems, like a thickened heart muscle versus a stiff valve. It's almost like stress testing the plumbing system while listening to the pipes.
Exactly. And because the heart and lungs share the same tight real estate in the chest, the lung exam is equally critical. The doctor taps on the chest to listen for dullness or hyperresonance, and listens for the quality of breath sounds, air entry, wheezing, bronchial breathing.
This is where we find some of the highest yield respiratory clues. If a doctor hears bibasal crackles, a popping sound at the bottom of both lungs, what is actually happening inside the lung tissue?
The tiny air sacs at the base of the lungs are filling with fluid. When the patient takes a breath, those fluid-filled sacs pop open, which sounds remarkably like pulling apart Velcro.
Whew.
Yeah, it's a classic sign of pulmonary edema, often driven by a heart that is failing to pump fluid forward, causing it to back up into the lungs.
On the other extreme, if they tap on one side of the chest and it sounds hollow like a drum, like it's hyperresonant, and there are completely absent breath sounds on that side, that is a tension pneumothorax, right?
Yes, a one-way valve tear in the lung, where air gets into the chest cavity but can't escape. Pressure builds up until it physically crushes the heart.
Which highlights why the investigation doesn't stop at the chest. The chest is connected to everything else. Sometimes the root cause of chest pain is hiding in the belly, the back, or even the legs.
So true. Moving down to the abdomen, the doctor presses on the area right below the ribs, checking for epigastric tenderness, an enlarged liver, or ascites, which is fluid pooling in the belly.
Why would the liver be enlarged from a heart problem?
Well, if the right side of the heart fails, it creates a massive traffic jam in the inferior vena cava, the main vein bringing blood up from the lower body. That traffic jam backs up directly into the liver, swelling it like a water balloon, which the doctor can feel with their hands.
Wow. The protocol also highlights the search for a pulsatile abdominal mass. If the doctor feels a rhythmic, pulsing lump in the center of the abdomen, they are feeling an abdominal aortic aneurysm, the aorta bulging out dangerously in the belly, radiating pain all the way up into the chest.
Right. And if we connect this to the bigger picture, the vascular system is a closed loop. That's why doctors are prompted to examine the calves. They look for unilateral leg swelling, where one leg is noticeably larger and more tender than the other.
Right, but how does a swollen calf translate to crushing chest pain?
It traces the journey of a clot. Deep vein thrombosis, or DVT, is a blood clot forming deep in the leg veins. If that clot breaks loose, it becomes an embolus. It travels up the leg, passes through the right side of the heart, and gets pumped directly into the lungs, where it violently wedges into the pulmonary artery.
A pulmonary embolism, a massive roadblock in the lungs causing sudden, severe chest pain and oxygen starvation, entirely originating from a silent clot in the leg weeks prior. The detective work required to connect those dots is just staggering to me.
It is medical sleuthing at its finest.
Truly. And the source text actually provides a cheat sheet of high-yield physical findings. These are combinations of small clues that unlock a massive diagnosis.
Oh yeah, the ultimate diagnostic combination from the source is a triad of specific signs. Hypotension, which is low blood pressure, combined with a raised jugular venous pressure in the neck, combined with muffled heart sounds.
The ultimate diagnostic combo. Let's break down the mechanics of that triad.
Okay, it points unequivocally to cardiac tamponade. This happens when fluid, usually blood, rapidly fills the pericardial sac surrounding the heart. The sac is tough. It cannot stretch fast enough to accommodate the fluid. So the fluid expands inward, violently squishing the heart. Because the heart is physically compressed, it cannot expand to fill with blood. If it can't fill, it can't pump, causing an immediate severe drop in blood pressure. That's the hypotension.
And because the heart is squeezed tight, all the blood trying to return from the head and arms hits a roadblock. It backs up the pipes into the jugular veins in the neck, causing them to visibly bulge. That's the raised JVP.
Exactly. And finally, the doctor's trying to listen to the heart through a thick, newly formed wall of fluid. The fluid physically dampens the acoustic waves, making the heart sound incredibly distant and quiet.
Low pressure, bulging neck veins, muffled heart. 3 physical signs gathered with nothing but a stethoscope and keen observation, telling the doctor exactly where to insert a needle to drain the fluid and save the patient's life.
It's amazing.
So what does this all mean for you listening right now? We've just walked through an incredibly dense 12-step protocol that an ER doctor executes in mere minutes. They process a staggering volume of information, turning physical quirks, a splinter in a fingernail, a delayed pulse, a crunching sound, a swollen calf, into a 3-dimensional working map of your cardiovascular system.
It demands an appreciation for the intensely interconnected nature of the human body. A pain in your chest might actually be an alarm bell for a torn pipe in your neck, a blood clot that formed in your leg, or a silent battle with high blood pressure that is only visible in the microscopic vessels behind your eyes.
We started this deep dive talking about the perceived chaos of the emergency room and how this clinical map brings profound order to that chaos. It relies on rapidly analyzing a web of silent, interconnected symptoms to find a hidden root cause rather than just treating the most obvious side of the pain. Which leaves us with a final thought to mull over today. What if we applied this exact kind of systematic, holistic symptom check to the other crises in our lives? When we experience acute stress, severe career burnout, or sudden friction in our relationships, we almost always hyper-focus on treating the most obvious pain point. But what if we took a step back, mapped out the connected systems, looked for the hidden clues, and treated the root cause instead?
So here we come to the summary of acute chest pain, clinical examination, a systematic protocol for identifying both common and life-threatening emergencies. A patient with pericarditis may be sitting up, well, just like heart failure patient, and acute coronary syndrome patient may be lying down, not moving. Maybe patient is in distress, pallor, diaphoretic with cold sweat, cyanosis, restlessness, cachexia, and if the patient is looking obese. This is a general eyeball survey. You just look at the patient and note these clues. You look for the patient ability to speak and his pattern of breathing. Looking for any respiratory distress, accessories, muscle use. Checking saturation of oxygen with your oxygen probe. Looking for peripheral perfusion, skin color, capillary refill, legs and hands for any coldness and sweating. Looking for agitation, confusion, any disability that is clearly visible in neurological status. Then you expose the area of chest pain and look for the chest wall, skin lesions, any trauma, rash related to herpes zoster. Jotting down blood pressure, heart rate, respiratory rate, saturation of oxygen and temperature is of paramount importance. Should be done promptly after having a general look on the patient. Extremely essential that saturation of oxygen is above 94%. Then you come on to the hand examination. You look for cyanosis, clubbing, nicotine staining, splinter hemorrhages, xanthomas, and palpate for temperature, capillary refill, and radial pulse for rate, rhythm, volume, character, radial, radiofemoral delay, and any pulse deficit that could be elicited should be promptly evaluated for. A low blood pressure with raised GVP, muffled heart sounds is tamponade. A high blood pressure with 3 or grade 4 retinopathy is malignant hypertension. And asymmetry in arm blood pressures are pulse deficit may point out to aortic dissection or atrial fibrillation leading to pulse deficit. The difference between the blood pressure in two arms should be taken seriously in chest pain. Moving up the neck, looking for JP carotids and carotid bruit may be listened for, and you can see pallor, cyanosis, and sweating on face. In the eyes, pallors and thalasmas, and fundoscopy for papilledema, hemorrhages, any lesions of infective endocarditis, and then come to trachea for its position and its any crepitus palpable in the vicinity may give a clue. Then you come to inspection for scars, deformity, and any visible pulsation. Any devices like a CDR pacemaker and apex beat are inspected on precordial examination. On palpation of precordium, apex beat for its location, character, peristernal heave, thrills, any costochondritic related tenderness, any epigastric pulse. Percussion is usually not done for cardiac area as it is too not specific, but other things should be done. Tenderness in the chest may be pulmonary embolism. It is not necessarily always costochondritis and should not be neglected, especially in a patient with shortness of breath. Labeling a tender chest as a costochondritis could be dangerous thing. Auscultating all the areas mitral, tricuspid, left upper sternal border, right upper sternal border, right lower sternal border, and left lower sternal border tricuspid area for any murmurs, and making the patient doing Valsalva or standing for differentiating between hypertrophic cardiomyopathy and aortic stenosis, which both cause chest pain. And patient may be leaning forward during exhaled position for auscultation in the base of the heart for aortic regurgitation as a cause of chest pain or dyspnea. The sequence should be maintained. Patient should also be moved to left lateral position to hear for any mitral murmurs, and if any murmur is discovered in a mitral area, it should be mapped to its location of radiation to axilla or anterior chest, and it will give the cause. A new diastolic murmur may be AR with aortic dissection. A systolic murmur may be papillary muscle rupture or ventricular septal rupture if the patient presents late after myocardial infarction. These things usually are very dangerous scenarios. With VSR, the patient is in cardiogenic shock, while in papillary muscle rupture, the patient is in pulmonary edema. Given a lot of pulmonary edema, the murmur of MR might not be audible clearly. Respiratory assessment for inspection, symmetry, respiratory effort with palpation for chest expansion, trachea position, tactile fremitus, and percussion for hyperresonance or dullness, and auscultation of air entry, crackles, wheezes, bronchial breathing, pleural rub, and bibasal crackles. Unilateral absent breath sounds and hyperresonance test in pneumothorax by bibasal. Bibasal crackles are usually pulmonary edema linked to acute coronary syndrome or a complication of myocardial infarction. Peripheral vascular examination for edema of peripheral limbs and peripheral pulses with pulse symmetry, unilateral leg swelling with pulmonary embolism and calf tenderness and DVT, abdominal examination for epigastric tenderness, any pulsatile abdominal mass, hepatomegaly and ascites, and back examination for thoracic spine tenderness, chest wall tenderness and scapular tenderness, chest wall vesicular rash, herpes zoster may be causing a burning chest pain and may be severe, not relieving with usual treatment. Aortic dissection may have different clues of giving the neurological events, back striate of hypotension, raised GVP, and muffled heart sound. while mediastinum may have precordial crunching synchronous with heartbeat that is called Hammond sign, and subcutaneous crepitus, both palpation and esophageal perforation or pneumothorax due to any other cause may be there. So aortic dissection, backstriate and pneumomediastinum and Boerhaave syndrome should also be clearly looked for. S3 gallop is heart failure, precordial friction rub is pericarditis, localized chest wall tightness, musculoskeletal pain, chest wall, vesicular rash, herpes zoster, unilateral leg swelling, pulmonary embolism, calf tenderness, DVT, and grade 3 or grade 4 hypertensive retinopathy is hypertensive crisis. Protocol should be rapid and to the point, and nothing is worth omitting in this scenario in physical examination of a patient with chest pain.